Hello and welcome everyone. Today we will be discussing the topic that is fever of unknown origin. The febrile response thermometer came to the mainstream with the work of Wunderlich in 1868, where he established that the normal body temperature is 37 degrees centigrade using over a million axillary readings. Now, since the 19th century, the body temperature has gradually declined, with current normal ranging from 36.3 to 36.5. Now, the decline in the body temperature may be attributed to inflammatory, environmental, and other changes over the last 2 centuries. So, how does fever occur? The preoptic area and the anterior hypothalamus are crucial for thermal homeostasis. Pyrogenic cytokines like interleukin 1 and interleukin 6, induced by pathogens and inflammation, trigger the production of prostaglandin E2 by the brain endothelial cells. The prostaglandin E2 resets the thermoregulator set point in the preoptic area into a febrile response. The preoptic area also regulates other thermoregulatory responses such as cutaneous vasoconstriction, non-shivering thermogenesis, and shivering thermogenesis. Fever-related anorexia is mediated by prostaglandins. While pyrogens induce fever, counter-regulatory cytokines like interleukin 10 and endogenous antipyretic mediators act as cryogens to prevent excessive temperature elevation. Now, what is the sequelae of fever? The perception of fever has changed over time, with ancient scholars viewing it as beneficial and the 19th century perception that it is harmful. The phylogenetic conservation of fever across millions of years in the animal kingdom suggests that it definitely has some potential benefits. These benefits are: the fever inhibits the proliferation of the pathogenic bacteria, which are mesophiles, organisms that thrive at temperature around 35. Now, fever promotes the production of hepatic iron sequestering compounds that bind free iron, which is responsible for the microbial replication. Febrile temperatures enhance the antimicrobial activity of the antibiotics, induce heat sensitive shock proteins that activate the host defenses, and boost the T cell responses. Studies indicate that temperatures up to 39.5 in critically ill do not have any adverse effect and may be associated with even better outcomes. So, external warming. Unlike fever, external warming through external means doesn't actually provide the same response that we get from fever. So, the beneficial effects of fever cannot be replicated by externally warming a patient. So, there have been some historical shifts in the pyrexia of unknown origin causes. Over the past century, there has been significant changes in the causes of pyrexia of unknown origin. Earlier in the 20th century, infections were the primary cause of unknown origin fever. In recent years, there's a perception that autoimmune and auto-inflammatory conditions have become more common. There is a complexity in the current situation. Despite the prevailing beliefs, studies show more complex scenario that in fever of unknown origin, the cause significantly varies even from hospital to hospital, country to country, and patient population to patient population. The literature presents contradictory findings, with some systematic reviews from various periods indicating that infection still remains the main cause of fever of unknown origin. Now, India and Turkey in 2021 accounted 40% of fever of unknown origin to infection, whereas autoimmune and inflammatory were responsible for only 25%. Now, conversely, studies in Japan, Greece, and South Korea indicate that it is the autoimmune and inflammatory conditions which are equally or more prevalent than infection. Even in current era, up to 51% of fever of unknown origin still remain undiagnosed despite all tests. So, first we have what is called as the classification of the fever of unknown origin. Regarding the definition, there is a lot of confusion. Some say it is 3 weeks, some say it is 3 days, considering we have more fast tests and rapid results coming in. So the traditional classification is divided into 4 categories, that is classical, nosocomial, immune deficient, and travel associated. Now, this classification, despite its limitations, offers an actual practical framework for evaluating patients who have prolonged fever. This is the classification: the classical, the nosocomial, where you can divide again between ICU and non-ICU, immune deficient, They can be divided into organ transplant, patients with neutropenia, hematopoietic cell transplant patients, and patients with HIV. And finally, you have the travel associated, and these are the various causes which are associated. We'll delve into the details of these. So coming first to the traditional, that is bacterial infections. Now, tuberculosis is a common cause of fever of unknown origin and it is prevalent in non-US studies at around 10% and in US studies around 5%. Miliary and disseminated tuberculosis is particularly challenging to diagnose, and Whipple's disease, approximately 38% of the patient present with fever, often alongside symptoms like arthralgia, diarrhea, and weight loss. Salmonella, both typhoidal and non-typhoidal, can cause fever of unknown origin and may be complicated by mycotic aneurysms. Finally, other notable bacterial infections include culture-negative infective endocarditis, deep-seated infections like abscesses, and prostatitis. Now, coming to viral infections. While most viral infections are symptom-limiting, diagnosing them can be very difficult. And a study in China found that human herpes virus were detected in 1/3 of the patients with fever of unknown origin. Now, herpes often presents by reactivation rather than primary cause of fever of unknown origin. Mononucleosis, it should be considered as a cause, especially when there is a varied presentation with age. Next is fungal infections, endemic mycosis, conditions like histoplasmosis, blastomycosis, coccidioidomycosis can cause unknown origin fever in both immunocompetent and compromised hosts. The distribution of this mycosis is shifting, making histoplasmosis a considerable even outside its traditional endemic areas. Then we have opportunistic mycosis like aspergillosis, cryptococcosis, which predominantly affect the immunocompromised. Zoonotic and vector-borne diseases, about half of the human pathogens are zoonotic, often described presenting as fever of unknown origin. Diagnosis is often delayed due to non-specific symptoms and lack of clear exposure history. Cancers can also present with fever of unknown origin in up to 2 to 25% of some cases, with common neoplasms like renal cell carcinoma, lymphoma, hepatocellular carcinoma being the most common causes of fever. The naproxen challenge has been suggested to differentiate cancer-related fever from infection, though it doesn't replace the need for thorough evaluation. Now, autoinflammatory and autoimmune, again, they are nowadays considered the more important causes of fever of unknown origin. Up to 32% of the cases of fever of unknown origin related to this category. Autoinflammatory conditions like related to innate immunity, while autoimmune is evolved with the adaptive immunity. Common conditions include giant cell arteritis, polymyalgia rheumatica, adult onset Still's disease, immune reconstitution syndrome, a new cause of fever often seen in immunocompromised patients related to immune system recovery leading to an inflammatory state. Miscellaneous causes and drug-associated various other conditions can cause classical fever. Drug-associated fever account for 3 to 7% of the febrile episodes in hospitalized patients, with antibiotics being the most common cause. Now, hyperthermic drug reactions include serotonin syndrome and neuroleptic malignant syndrome, which can either be idiopathic or drug-induced. So this is the table which shows the various type of drug reactions. You can have a hypersensitivity reaction where the fever can develop up to 7 to 10 days. Chemotherapy related, which can develop 3 to 19 hours. Infusion, which can occur quite early. Stress, which can be prolonged up to some weeks. Then you have hyperthermia syndromes, the serotonin syndrome, the malignant hyperthermia syndrome, the neuroleptic malignant syndrome, adrenergic fever, anticholinergic fever, mitochondrial uncoupling oxidation phosphorylation. So these are various type of fevers. You can go into the details of which particular drug can cause which type of reaction. The next is the nosocomial fever. There is an increased incidence because advances in medical care has led to rise in cases of this type of fever, especially in hospitalized patients, and because they keep on developing a lot of. So we have to have some distinct workup for this group of patients. Now, the focus is primarily on nosocomial infections, which are seen commonly in chronically ICU patients. The initial assessment should look for vascular catheter related infections, urinary catheter related infections, pneumonias, intra-abdominal infections, sinusitis, and Clostridium difficile infections. Non-infectious causes should not be forgotten because they are very important, and one of the most significant causes of fever in ICU, up to 31%, is non-infectious. So non-infectious causes include neurogenic fever due to cerebral injury, which is very common, thromboembolic events, which are again very common, drug-induced, as we have seen previously, most of the people are on some kind of a drug which can develop a reaction, and the frequency and degree of leukocytosis is similar in both infectious and non-infectious, make it is as an unreliable sign of distinguishing factor. So do not rely on the TLC counts to look for infectious or non-infectious causes. Now, immune deficiency category, the impact of immune suppression and immunostimulatory therapy. The rise in use of therapies like biological agents, monoclonal antibodies, CAR T cells has resulted in increased incidence of fever of unknown origin. The uniform definition of fever in immunodeficient patient is challenging due to the diversity of the immunocompromised condition, time and quality of the criteria based on the underlying host factors. Now, patients with HIV. The causes of fever are, in patients with HIV, fever is a result of the acute retroviral syndrome presenting as mononucleosis. In patients with AIDS, common causes of fever are opportunistic infections, mycobacterial infections, CMV, leishmaniasis, lymphoma. Antiretroviral therapy has reduced the prevalence of AIDS-related opportunistic infections, transforming HIV into a chronic disease. The workup for the fever in this type of patient should be similar to those individuals without HIV. Now, the immune reconstitution syndrome should be considered as a fever of unknown origin cause after starting the antiretroviral therapy. Organ transplant patients, the prevalence and incidence is around 1.4%, with infectious being the common cause over here. Improved antiviral prophylaxis has reduced the incidence of viral infections. The other causes include hyperinfective syndromes such as strongyloiditis, disseminated histoplasmosis, immunological and surgical complications, serum sickness, graft versus host disease, hematophagocytic syndromes. Patients with hematological cancers. Now, fever is a common finding in hematological cancer who have neutropenia. Neutropenic patients, that is absolute count less than 500 for more than 7 days, are prone to these type of infections. Despite broad spectrum treatment, fever often persists for a median of 5 days. If neutropenia fever lasts more than 7 days, empirical antifungal is recommended. Fever in hematopoietic cell transplant patient can result from wide range of causes, including infections, graft versus host disease, the cancer relapse, idiopathic pneumonia syndrome. CAR T cell, again a new therapy. Fever occurs 92% of the patients who have received this therapy, with a condition that is termed as cytokine release syndrome. Now, CRS related fevers are severe. While antibiotics are administered, the workup is often inconclusive. Anti-cytokine therapy like tocilizumab or steroids are recommended due to the harmful effects of high-grade CRS. Now, next we have patients receiving other immunosuppressive therapies. We need to have a good evaluation of the risks. Fever in patients with immunosuppressive requires careful evaluation for both common and opportunistic infections. Anti-TNF alpha therapies associated infection like listeriosis, herpes zoster, and granulomatous infections. Now, rituximab is linked with osteoarticular infections, invasive uroplasmal infections. Now, checkpoint inhibitions can cause inflammatory reactions like fever, organ inflammation, rash due to the enhanced immune response and autoreactivity. So, the returning travelers and fever of unknown origin increase in global travel has occurred. By 2030. It is estimated that approximately 2 billion people will travel annually, mostly to countries with emerging economies. Now, despite a decline in the international tourism due to the COVID-19, fever illnesses remain a common issue among travelers. The common infection in travelers are in the 1996 to 2011, a study found that the medical care revealed 4.4% had an acute illness. The most common infection for the travelers were malaria, 76.9%, enteric fever, 18%, leptospirosis, 2%. Then the median time to travel to the onset of symptom was 16 days, and 91% of the travelers with acute illness presented with fever. The mortality rate was 0.4%. Coming to the life-threatening and transmissible infections, early recognition of the life-threatening or transmissible infection is critical. These include the viral hemorrhagic fevers like Ebola and Lassa fever, leptospirosis, rickettsial diseases like typhus, measles, enteric fever, tuberculosis, influenza, severe corona infection, antibiotic resistant bacterial infections. These infections can be difficult to diagnose unless specifically considered in the differential diagnosis. Vaccine preventable diseases, many travel related infections are preventable by vaccine, yet a study showed that only 20% of the travelers with vaccine preventable disease had a healthcare encounter before traveling. So we need to have a diagnostic approach. So the approach is, in the initial evaluation, take a proper history, again do a proper physical examination, and then look for the diagnostic test. The diagnostic clues should be pursued, but while they lead to diagnosis in 62%, they can mislead in 81%. So the caution with extensive testing should be done. Since many fever of unknown origin involve uncommon presentations of common conditions, extensive algorithm-driven lab tests are discouraged due to the risk of false positive, particularly when the pre-test probability is low. So always keep in mind it is the uncommon presentation of the common condition which is more likely rather than some uncommon exotic disease. Tests like procalcitonin and beta-D-glucan may be valuable in specific infections, but they should not drive treatment decisions in patients without clear evidence of bacterial infection or invasive mycosis. So do not interpret these tests on their own. Take the patient's clinical history, the presentation, then only interpret these tests. Do not use these tests to make a diagnosis of bacterial sepsis or fungal sepsis. Revisit the history and the travel related uh, information. If the initial evaluation was inconclusive, the clinician should visit the patient's history again for new clues. Temporal artery biopsies may be considered in elderly to rule out temporal arteritis, particularly when other evaluations has yielded no diagnosis. Laparotomies, once common in fever, are largely replaced by CT scanning. So next we have advanced diagnostic, that is PET scan. We can use these scans with sensitivity as high as 98% and specificity as high as 85%. The scans yield is over 50%, significantly higher than conventional CT, and it is particularly effective in identifying infections and neoplasms, though less useful in autoimmune conditions. A negative PET scan result is associated with high likelihood of spontaneous fever remission. Drawback is that it is extremely costly and the availability is limited to tertiary care centers. Molecular diagnostics include the next gen sequencing and PCR. They are very advantageous and very rapid tests, but they are not very sensitive. So interpreting the results of these tests need to be done based on the history, obviously. Now, while these methods show promise, data on the routine use is not something which is encouraged right now. Regarding the management, we need to be cautious with the empirical therapy. While it is tempting to start an empirical antimicrobial or anti-inflammatory in patients with protracted fever, it is advisable to avoid this unless the patient is neutropenic, severely immunocompromised, experiencing a rapidly deteriorating clinical condition. The rationale is that undiagnosed fever of unknown origin generally has a good prognosis and may experience spontaneous remissions. Empirical therapy can lead to issues such as development of antimicrobial resistance. If the patient never had an infection, giving the antibiotic is going to promote resistance. Suppression of fastidious pathogens. False reassurance in cases of self-limiting conditions like viral infection, where you give the antibiotics and after some days you say the fever goes down, but that would have as such gone down because it was a viral etiology. Delaying diagnosis if anti-inflammatory agents resolve fever temporarily. Now, therapeutic trials can be done in cases with initial evaluation providing strong diagnostic clues. Clinical judgment should be applied in deciding whether to initiate therapeutic trials or specific drugs like antitubercular, doxycycline for the rickettsial illness, antifungals, steroids, while awaiting definitive diagnostic results. So, when to give the trial, we need to see the clinical status of the patient. So finally, this is the algorithm and the flowchart which you can use for evaluating fever of unknown origin in your patients. So first is detailed patient history, physical examination with careful attention to the skin, joints, lymph nodes, the medications, including the antibiotics, a detailed travel history, an important dietary history, and animal exposure. All need to be revisited and taken all over again. Confirm that there is actually fever. Withhold antibiotics if the patient is stable and not neutropenic. This is very important. Determine the need for hospitalization. Next is you can do minimal fever of unknown origin evaluation like basic panels, or you can go for advanced based on the clinical status of the patient. So after all these tests, you can make a diagnosis, then treat accordingly. Consider an empirical course of doxycycline, antifungal or tubercular pending the result of diagnostic test if you have a high risk of suspicion. Now, after all this test, if the patient still doesn't have a diagnosis, then please again go back, retake the history, redo the clinical examination, consider the other fastidious causes of fever. If the fever has not self-resolved, do a PET CT. If the PET CT or additional tests reveal something, pursue the diagnostic clue and give the appropriate treatment. If additional tests or imaging are not revealing anything, consider metagenomic testing with plasma and other body site to assess for infection. If the metagenomic testing is not feasible, consider empirical anti-inflammatory therapy if not contraindicated. Consider informing the patient that up to 50% of the cases may not have a diagnosis, and advise them to watchfully wait. So do not give false assurances that we will definitely do a diagnosis. 50% cases are undiagnosed. So we need to watch out. We need to follow up with the patient, see if it is spontaneously resolving or we are getting some new symptoms for whatever condition the patient is having. Thank you for your patience.